Hey everyone, how's it going? We are going to start a conference now. So we're going to do a Zoom conference today. So this is going to be a bit more of a diagnostic conference. We've got 2 recent admissions to the VA in the past 72 hours or so. Both of these patients, as the title implies, so short of breath, just thinking about the VA, are going to have shortness of breath, and we're going to go from there. So we're going to talk about big differentials for shortness of breath and then some workups for a couple more specific conditions. I'm sitting in the room with a good combination of interns, residents, and students. And then everyone who is watching via the chat, please do not hesitate to participate via the chat or just talking out loud. All right, so because one of our residents who's gonna tell us about this case or just give us updates is in here first, we are gonna start with case number 2. So case number 2, if I can get this all on the screen there. We've got a 51-year-old lady coming in with weakness and dyspnea. Her vitals in the ED, 36.7, 106, 116/64, setting 100% on ambient air. She's a 51-year-old woman with anemia, GERD, had a recent PE in 12/20, so 3 months ago. She's on therapeutic anticoagulation with Xarelto. She's presenting with weakness. She reports acute on chronic weakness with recent nosebleeds in the past few days. So, because this is more of a diagnostic case, we'll ask the people in the room first and people in the chat, how would you guys start to think about this person's weakness, shortness of breath, just hearing this initial history? Cool, so Mallory says symptomatic anemia. And Mallory, why'd you say symptomatic anemia? Awesome. So Mallory hit on the context clues. We're working out some kinks here in the room real quick. Got it. All right. So yeah, Mallory hit on context clues. She's got anemia. She was recently started on anticoagulation. So symptomatic anemia is an awesome first choice. What else are we thinking? Cool, so Carl goes to CTEF, I love it. So recent PE, thinking CTEF, perfect. Any other big buckets you guys think about for shortness of breath? Yeah, great. So in previous years, maybe we'd throw the dyspnea pyramid up here for 2 lane related reasons. We are no longer going to teach about the dyspnea pyramid. But yeah, so Merrill brings up an excellent point. So what we used to call the dyspnea pyramid, we're now gonna go with the dyspnea square. That's what we're gonna go with here. So dyspnea square. So one of those boxes is cardiac. One of those boxes is going to be pulmonary. Other box that Mallory hit on is going to be blood related, and then our very last box there is going to be acid base. Awesome. So if you guys were betting people, which one of these boxes would you guess this person's going to end up falling into with her history? Mallory's sitting over there nodding like I am the smartest person alive. Awesome. So she's going to fall into this blood category. So let me give you some labs here. So does anyone want to take a guess what this person's initial hemoglobin is going to be? We got bets for 4. Anyone else got bets?
I'm guessing 3.8.
Wow, that is really, really specific, but
suspiciously specific.
Almost correct. So this person's initial hemoglobin is 3.9. Platelet count is 520, and then I'll just run through notable stuff on the BMP. She got a bicarb of 19, 11, 1.1. 85, and then her LFTs, take my word for it, are essentially normal. Okay, so one of the really important teaching points here early on is based on this person's vitals and her labs, if you guys were gonna dichotomize her into acute bleed or acute on chronic bleed, what would you think? All right, great. We got some murmurings for acute on chronic, and why are we thinking this is probably acute on chronic? perfect. So Jess is hits the nail on the head. So if this person went from a normal hemoglobin to 3, she would probably have died or actively exsanguinated. And then the other big context clue here is this heart rate of 106 and essentially what's probably a normal blood pressure or a slightly low normal blood pressure. So the medical students have heard me talk about this, but there is something called the shock index, which we don't use too much in medicine, but they use it a little bit more in surgery. Does anyone know what the shock index is? Yeah, awesome. So Mike says it takes into account your heart rate and your blood pressure. So the shock index is basically your heart rate over your systolic blood pressure. And so I think we can all agree that if your heart rate is above your systolic blood pressure, that is bad. Those are two numbers that should not be in that ratio. And so there's actually pretty good validated data that if this number is greater than 0.9, it's associated with increased mortality from bleeding, increased transfusion requirements, and essentially more extensive trauma care. This is more of a surgical marker, but it's sort of a good way to like theoretically conceptualize acute on chronic GI bleeds or acute GI bleeds. I will say the big caveat here is if your person is on a beta blocker, that heart rate might look a little bit lower than usual. And so that's another plug for always looking at the medication list. Anything else you guys, any other thoughts on this initial hemoglobin about where the blood might be going, what we're missing? Any additional tests that you would want right now, lab work wise? Rectal exam, great. So rectal exam is negative, I believe, Mindy? Great, rectal exam is negative.
I feel like there's like only a certain amount of places in your body you can do something with, right? Legs, stomach, lungs.
Great, so we're thinking, where's the blood? So if rectal exam is negative, we're not seeing signs of blood in the bowel movements or anything like that, correct, Mindy?
Yeah.
Yeah, so not seeing any signs of blood in the bowel movements. So where else can that blood go? So what are those big compartments? Great, so abdomen, RP, I heard lungs being thrown around, the thighs can do it as well. Pelvis as well, awesome. So I'm actually not sure if this is going to be relevant for the case, but something good to think about if your rectal exam is negative, sort of evaluating these other spaces to see where your blood's going. Meryl, any additional labs that you would want from this person's to further work up that CBC?
I mean, I think they're like obviously acutely bleeding. I'll probably eventually get an iron and ferritin, just to assess the sort of chronicity.
I love it. Iron and ferritin. I can also give you that her MCV is 75. Anything else anyone wants? Great. A retic count, always helpful. He said sarcastically, but I like it as part of this workup. All right. Her iron count. Anyone want to have a guess how low this is going to be? 4. It is 10. Her ferritin level is less than 4, so what is basically an undetectable ferritin. And her retic count or percent is 3.4%, which I'll tell you is high. So we are working here with what type of anemia, just so we're all on the same page. So great, so acute on chronic, blood loss anemia. And if you were like, right, creating your hashtags, your second hashtag might be like FE deficiency anemia. Cool. Any questions so far about this person's initial lab workup, presenting findings? What's that? Good question. Mindy, menstruating? So for people listening, Jess asked a really good question. Is she menstruating? So other sources of blood loss.
So the one thing I was going to say too, is her retic count, do you think that's too low or adequate, or is there an equation you can do to see if that's adequate or not? Yeah, somebody said retic index. So I was going to say like that's definitely too low. Her retic count.
I do not have a retic index on her, but yeah. There's also some other like obscure tests you can do whenever someone has a microcytic anemia. So if anyone's familiar with like the Menser's index, has anyone ever heard that term before? It basically looks at your MC. I know I have to one up Corey's obscure esoteric anemia knowledge. So this index basically it helps kind of rule in or out the thalassemias based on what your MCV is in relation to, I believe, your like red blood cell mass. It's in the purple book that we all pay a lot of money for in med school and then never open up again. So if you were interested in cracking that bad boy. All right. So how would you guys, so we'll go back to our initial history. How would you guys approach this this workup? Like, so we'll pretend she was admitted last night, even though it was a couple nights ago. What would you talk about on rounds? Who would you call, next steps, et cetera?
Yeah, like I think she's like a really good physical exam before anything else. Like, is she bruised somewhere? Is her flanks hurt? Is there any sign, external signs of blood somewhere?
Cool.
Yeah.
Cool. So physical exam, we're gonna clarify in the morning whether or not she's got melena. Okay, so we're gonna do the rectal exam too, again, just to make sure. And what would you be ultrasounding, Matt? Oh, sorry, Matt. It was Clint there. Sorry, Clint. What would you be ultrasounding? Awesome. So ultrasounding to see if she's got sort of maybe free fluid in her abdomen or something like that. Great. And then what services would you guys think about consulting? I think GI is going to be an easy one, but any other person you might want to talk to here? Oh my gosh, how did that get so large on the screen? I like it. So I guess this is a good question. Like, when do we talk to ENT for the GI, for a patient that we think might be having a GI bleed or a bleed? Does anyone in here have a framework for when we get ENT involved in the anemia workup? Yeah, great. So, right, if you're getting a history of nosebleeds, so that's a pretty easy giveaway. So if you're giving a history of epistaxis, like, you should probably talk to ENT if it's an inpatient type of thing. But if we're actually talking about what's easier, like a laryngoscopy is a way easier procedure to perform than an EGD and a colonoscopy. It doesn't really require sedation. It can be done much faster. And so if the clinical history is pointing you one way or the other, you can probably knock this one out faster. And if you knock this out and there's no bleeding into these other spaces that we mentioned over here, the last place you have to look is colonoscopy, EGD, and sort of get your intraluminal eval completed. Cool. And then Carl says he has a question about IVC filters. So this degree of GI bleed might amount to inability to tolerate anticoagulation. I am going to defer that question to Mindy. Mindy, did you guys talk about anticoagulation on rounds?
We actually, she's coming up on the 3-month mark, so we just actually stopped it.
Cool. So Carl, Mindy said that this person is coming up on the 3-month mark for her PE, and so they're probably just going to stop it anyway. But a really good thought. So if you need long-term anticoagulation, when do we jump to the IVC filter, et cetera? All right, Mindy, give us some more updates. How's this person doing and what's happening now?
She has a lot of psychiatric issues that we're dealing with. Otherwise, her hemoglobin's been stable around 8 after getting transfused. ENT saw her yesterday. They did a bedside laryngoscopy. Didn't show any active bleeding. She had like a small abrasion on her left septum, but no like exposed vessels or anything that would really scream of bleeding. They also had a CT PE in the ED. She had a thoracentesis done when she was here last time, and she actually got a hemothorax from that, but it didn't show any thorax, and the PE that was unable to be visualized. And then she's going for her EGD and colonoscopy.
Cool. So EGD and colo today. Awesome. So we'll have some answers probably by the end of the day. So really nice, like really basic, profound anemia workup. Coming in 3.9, sees ENT, gets transfused, and goes from there. Cool. Anyone have any questions about this lady's dyspnea or shortness of breath? I like it. Mindy, just for sort of logistical stuff and for, interns, you guys are going to be ordering a bunch of transfusions, obviously, this year and next year. How many units of blood did it take her to get to 8? 4 units. Awesome. So that's like a perfect correlation. So right, every unit you should increase by about 1. So almost a perfect correlation. And then Mindy, did you guys recheck a CBC in between, or did you give a couple units and recheck?
It was overnight, so we actually did. After like 2 units, we got a check.
Awesome. Yeah. So Mindy said, for those that couldn't hear, that they rechecked after a couple units and then kept transfusing. And that's an awesome way to manage this. So you don't necessarily need to get a CBC after every unit of blood. The blood bank will tell you to do it after every unit of platelets because that's a bit more of a scarce resource. But checking every 2 units or every 3 units in a situation like this, if the person is hemodynamically stable, is definitely appropriate. And then just for kind of an intern medical student question, if this person was hemodynamically unstable, how would you transfuse her? There we go. You've activated the massive transfusion protocol. I love it. Huh?
You talked about that.
Yeah, so Meryl did this awesome talk with the students here today. So if he was hemodynamically, so HD unstable, right, you're going to activate your massive transfusion protocol. I've referenced this in the number of times this year in our conferences, but the data for this, we base it on the surgery literature called the PROPER trial. And that trial basically evaluated 1:1:1 versus 1:1:2, the 2 being the PRBC number. And what they found was 1:1:1 was associated with with better hemostasis and less units of blood used. So if you're doing the massive transfusion protocol, you do 1:1:1. The really confusing part is that 1 unit in quotes of platelets is actually 6 pooled platelets. And so to keep that ratio of 1:1:1, what you want to do is give 6 units of blood, 6 units of FFP, and 1 bag of platelets. And that keeps your 1:1:1 ratio intact. And then Dr. Chan awesome. Dr. Chan's asking about hemolysis rule out. I believe her LDH was normal. And then Ed Chan's also asking about aplastic anemia rule out, which is great. So if you look back at her CBC, 2 of her cell lines were down. One of them was close to being down. And then provoked or unprovoked PE. That's a great question. Mindy, provoked or unprovoked?
She actually considered provoked for severe psychiatric disease. She was not moving.
Gotcha. So for those that couldn't hear, sort of an interesting twist on the provoked factor, severe psychiatric disease and not moving, which is not one. That is not one you hear a bunch. All right. Cool. So really good first case talking about dyspnea, and we have knocked out the first table of our thing, which is the blood. All right. So back to our other cases up here. So this one over here was a profound symptomatic anemia, like Mallory expertly called out right off the bat. All right. Case number 1. So Meryl's team admitted this person overnight. Again, so workup is ongoing, but we've got some pretty cool imaging and stuff to talk about. All right. So this is a 74-year-old man with COPD, known pulmonary fibrosis, hypertension, hypothyroidism, iron deficiency anemia, presenting with a further evaluation for an elevated D-dimer by his PCP. I just want to say Matt Minturn took an excellent history and wrote an excellent HPI. So this is all thanks to him. Reports increased fatigue and generalized weakness, particularly with exertion for about the past 4 days. He's using supplemental oxygen at home, 3 to 4 liters per minute at baseline, and has been for some time. But he reports difficulty keeping his pulse ox at greater than 90% recently. In the ED, he's afebrile, his heart rate's 98. Blood pressure is 165/82, and he's setting 60% on 3 liters nasal cannula. I'll tell you that he is rapidly escalated to 15 liters non-rebreather, and he gets above 90 for the first time. So we'll presume that he is stable for the time being while we pontificate about his differential. So similar to last time, what are you guys thinking here for a differential for this gentleman's dyspnea? Cool. PE. I love it. And why are we saying PE? That's great, Mike. So D dimers up and then acute symptoms and sort of recent worsening. Love it. Yeah, Meryl's been sworn to silence till needed. COVID, great. So don't overthink this, guys. You guys have worked up dyspnea like hundreds of times at this point. So infection or COVID, awesome. Great. Again, don't overthink this. COPD, pneumothorax, perfect. What's that last bucket, that last square of the heart that you're not quite hitting yet? The other organ in the chest. You're killing Eric slowly right now, but cardiac, right? Cardiac.
How the heart has fallen.
So cardiac, just because Eric's not presenting the conference doesn't mean this is not the heart. Cool. So you guys, again, right, you're hitting that square. So, right, we're not doing the dyspnea pyramid anymore, but cardiac, pulmonary, those are kind of lungs, blood, and acid base. All right, cool. What do you guys want next in this person's workup? Your options are medication list, physical exam, chest x-ray, or those three. All right, we've got mutterings that his chest x-ray is very cool. So here's his chest x-ray. So we've got Dr. Chan on the call as well. So Dr. Chan can help us with some sort of expert analysis, but everyone take 30 seconds. And then I'm gonna ask one of the interns in the room, because we don't have a whole lot of upper levels, to give us their read. I apologize if the definition is not super good. All right. Crickets in the room right now. Everyone is like focused at a wall or a painting. No one is making eye contact with me. This is amazing. All right, brave volunteer to give me their focused read of this. And then I will actually defer to Dr. Chan then to give his thoughts on it as well.
I can talk about what we talked about on.
Yeah, that's perfect.
So essentially, you really see is like fine interstitial markings going, they're pretty prominent, going all the way out to the tweet bar, consistent with his pulmonary fibrosis. And then you can't help but notice how large his heart is. And he's definitely rotating a little bit, but even with that, he's got a pretty large heart. And Dr. Gore made a comment, what it was called, was that distance. It's like the distance between the aortic notch and the left side or the right, like atrium almost. And based on how like wide that is in particular, you can tell that someone might have some chronic pulmonary hypertension. And those are the things to talk about.
Awesome. Dr. Chan, what thoughts do you have on this chest x-ray?
Yeah, so I thought that the right hemidiaphragm, there's some obscuration there. And if you look at the lateral, you sort of see a spine sign. So I think that there might be some, yeah, exactly. So I think there might be some right lower lobe opacification there. And then his right paratracheal stripe is really widened. So, I mean, that could be azygos, that could be lymphadenopathy. And on the right cardiac border, I think that's probably a pulmonary artery that's really large. Yeah, so I mean, but I don't see any like obvious heart failure other than the cardiac enlargement and maybe the right lower lobe consolidation there.
Awesome. Thank you, Dr. Chan. Does anyone have questions about Dr. Chan's interpretation or read in addition to the stuff that Meryl brought up? Yeah, this is great. We don't get enough lateral x-rays because our patients, right, can't turn laterally, or they're portable, but this is another really great example of the spine sign. And then Dr. Chan, I think really importantly, like pointing out that right paratracheal stripe and the trachea right sort of pulled over as well. So the other thought I would have is there some sort of volume loss on that right side causing like a suction effect, and the trachea is being pulled. And then the other thing that may be important later, I'm not sure, wondering whether he's got like a splayed carina, so which can sometimes be a marker of left atrial enlargement as well.
Yeah.
Okay. All right. So to not delay this any longer, let's take a look at this guy's CT scan. So here's his CT scan. We're going to scroll through this a couple times to give you guys a chance to look at it. All right, I'm gonna play that one more time for you guys. All right, so what we're gonna do in our room here, just so we don't put the onus on one person to read this whole thing, we're gonna go table by table, and everyone's just gonna say one abnormality that they see. So you can go as low hanging or as specific as you want, but we'll start with the table furthest from me. Give me one abnormality that you guys saw on the scan. This is AB normal, a couple of AB normal findings. Great, so we've got blebs, perfect, awesome. So blebs, I'll tell you the official read on that was he's got some emphysematous changes, so awesome, great start. There's some stuff up there and much more prominent as we go down. Great. Table 2. Say it again. Great. So he's got some GGO, so ground glass opacities, distribution, maybe diffuse. But yeah, great. Love it. Kate's sitting in front of me, unfortunately. Kate.
Pleural effusions.
She got pleural effusions. Awesome. We'll go to Eric and Corey next, who are sitting kind of close to me. What do you guys think?
He's got like a leftover
Oh, wow. Corey went nodule out of nowhere. It's somewhere there. So Corey, he doesn't indeed have a nodule. There's a nodule somewhere, I swear, based on the official read. Great job, Corey. Dr. Chan, anything else that you noticed on this?
Well, his pulmonary artery trunk is as big, if not bigger, than the aorta.
Great. So PA trunk greater than the aorta. That's awesome.
You see the whole vasculature right there. Like those vessels are huge.
Great. So large vessels. Awesome. Perfect. And then Dr. Chan, what are your thoughts on this gentleman's interstitial lung disease pattern? I'll play it again for you. Corey's looking for his nodule.
Yeah, I mean, mainly lower lung zone, peripheral, increased reticular markings out in the periphery. I mean, that's consistent with, IPF, UIP pattern. I don't know whether he has a connective tissue disease as well. And I think I probably saw some honeycombing, although it's hard to know because he also has that paraseptal emphysema that you talked about. But I think that at the very right base, there was some honeycombing as well.
Great. That's awesome. So Dr. Chan has been doing this for a while and called out the sort of IPF pattern. So IPF is is sort of idiopathic pulmonary fibrosis. It's the radiologic correlate of that is UIP. So you have the UIP pattern, usual interstitial pneumonia. But if it's idiopathic, it then becomes IPF. So Dr. Chan hit all the key points there. So what is that UIP pattern? So it's lower lung zone predominant. It's subpleural or peripheral reticulation, and then it's honeycombing, and that gives you the typical UIP pattern. What Jess brought up, the question of whether or not this gentleman has ground glass opacities. So if you have a lot of ground glass opacities, that is actually not consistent with your typical UIP. So then you get into like less likely to be the UIP pattern. But yeah, this gentleman certainly has some. So I'll say his official read, they called it sort of non-specific interstitial thickening, and their thought was maybe NSIP versus IPF, and they asked for sort of more clinical history. So Dr. Chan's last teaching point, which I'm glad he brought up, was how large this gentleman's pulmonary trunk is. So here is a slice from his mediastinal windows on that CTPE, and this right here is his PA, and this is his aorta. And as you can tell, this is wider than his aorta. So that's like a really off the cuff way to see if your person has pulmonary artery enlargement. And the size you're looking for there is generally greater than, I believe, than 3 centimeters. And so you can measure that yourself with the ruler feature on whatever we call impacts here. So this gentleman has PA enlargement as well. Cool. Any questions about this gentleman's imaging for people in the room or on the chat? Yeah, Jess, good question. So he did indeed have a consolidation in the right lower lobe. If you look sort of right, it's there somewhere. It's like very small, but it wasn't as prominent as it was expected. All right, so I said this was mostly a diagnostic case, and it is because this gentleman actually has not had a whole lot of workup yet for his ILD. So what I want everyone to do is take like 30 seconds to a minute with the people sitting next to you and tell me how you want to work up this gentleman's ILD or his interstitial lung disease pattern. So what imaging do you want, and what additional lab work do you want? All right, great. We had some excellent discussion in here, and Kate and Corey have some good discussion as well. So let's start with imaging. What imaging do you guys want to work up this gentleman's ILD? Awesome, high-res CT, perfect. So we order these not insignificant, not infrequently. And so what does the high-res CT get us that your like run-of-the-mill CT does not? Because I'll tell you that the radiologist will tell you that this misnomer high res, all of our CTs now are high resolution. And so we say high res CT, but there's actually other stuff it gets us besides just that resolution. What are those things? Good question. So it is a little bit thinner slice, but according to our radiology chief resident, that's actually not a resolution issue. It's a misnomer, but yeah, so they're thinner slices, so you get more slices. What else? Jess said they got prone and then had like a lilt at the end of his sentence, kind of question mark there, but he's correct. So you get a prone image. What else do you get? Great. So you get inhalation and then you get an exhalation view. And anything else? And then you just get the normal pass down the chest. So you get a prone image, you get an inhalation and exhalational image, and you get a normal image essentially. So what does that prone view look like? Because we don't see that one as frequently. I took this from this gentleman's high-res CT. So this is his prone images. So these are going to be larger slices. And we'll run through that one more time. So why, for people in the room, why do we get the prone image? Great, Kate, what did you say?
You just see if stuff's dependent, like, or is this fluid loculated, is air traffic dependent?
Yeah, great. So you see if stuff is dependent, right? So you're really looking to see if there's like, wow, that green does not pop on the picture right there. So you see if there's like basically dependent atelectasis essentially, or all of this stuff back here, you're basically looking to see if that disappears or that stays when the person is prone, right? So if it stays when the person is prone, that means that it's likely an interstitial process and it's pathologic. Whereas if it disappears, it suggests that it's atelectasis. So sort of position-dependent atelectasis. So that's what go ahead, Dr. Stan.
Well, I was just going to say, so that view that you have there shows maybe some traction bronchiectasis as well. So you see not all of them, but the one on the left, maybe some of the airways are bigger than its companion pulmonary artery. So you see that's another sign for pulmonary fibrosis is when there's traction bronchiectasis.
Awesome. And Dr. Chan, what is your how do you think about traction bronchiectasis? Like when do you call that on a CT?
Well, when there's fibrosis and when the airway diameter are bigger than the companion pulmonary artery vessel.
Awesome. Great. Yeah, that's awesome. So anytime that airway, so the airway, right, being the black space is greater than the companion vessel, the white space next to it, you can call traction bronchiectasis. Perfect. So there's our prone image. I've showed you guys sort of, we already know what I didn't take the inhalational and exhalational images. And then we saw the normal image earlier. So I think more confusing and more useful for this guy's workup is his lab work. So just call out in the room and put in the chat what additional labs you want to get as part of your initial ILD workup. And the team who had this guy, feel free to chime in as well. And what antibody, just because Corey will kill me if I don't say it, what antibodies are the anti-Sjogren's antibodies? Yeah, great. So SSA and SSB, perfect. What else is in this initial ILD workup? Okay, anti-synthetase, and what antibody is that? Corey's slowly shaking his head more vigorously. Corey, what is that one?
Is it the TRA?
I think that's actually the XCL70, isn't it? Is that scleroderma?
Sounds right, yeah.
That sounds right.
SCL70 is.
So scleroderma. So Corey's telling me it's scleroderma. I'm incorrect. All right, well, agree to disagree.
I think it's just anti-synthetase.
Cool. And what else is on that workup? So we've got the, with the RF, I'll tell you the CCP is included in that as well. Dr. Schwartz at the U has done a bunch of research into this. And anything else you guys would want? All right, that's why we have experts. Dr. Chan, what else do you include in your initial serologic workup for ILD?
I mean, you can get CPK, I mean, just to make sure that it's not one of the, connective tissues that's associated with myositis, right? And then, so the anti-synthetase is directed against, its antibodies directed against transfer RNA. So, transfer RNA is those RNA that hooks onto amino acids to make protein during the translational process, right? And so for each of those amino acids, there's a different transfer RNA. So you can have an antibody against each of those transfer RNA. So there's many anti-synthetase antibody. And the most common one is anti-JO, JO. But you can have like, I can't remember, PL7, PL12, there's 20 of them.
Cool.
And then there's MD5 as well, which is not one of the anti-synthetase antibody, but it's amyositis, amyositis, polymyositis. So in other words, it's like polymyositis, except there's no elevation in CPK.
Awesome. So this is actually a really interesting one, this amyopathic, dermatomyositis, this DM there.
Yeah.
Dr.
Yeah.
Khan did some research in this when he was a fellow. And we've had a few patients in the U in the last year, but essentially they present with like the mechanic's hands, the gotcha papules, but no myositis symptoms, and they have this horribly rapidly progressive ILD. So there's actually a woman right now at the U on the transplant list or in the CTICU who has this, and it's really sad. But the only way to pick that up is on the myositis panel, which has just a whole host of antibodies. Cool. So any questions about the ILD workup before we talk about a couple more specifics of this guy's case? I'll say
well, history is very important, right? I mean, does he have exposure to radiation, asbestos in the past, organic antigens? I mean, typically pulmonary fibrosis from hypersensitivity pneumonitis. If it's chronic, it's typically upper lung zone, but I'm sure it can happen lower lung zone as well. And obviously drug history, you know, like amiodarone and, you know, like prior chemotherapy, whatever.
Awesome. Thank you so much, Dr. Chan. Dr. Chan was on pulmonary grand rounds this morning as well and crushed it. So he spent a whole day teaching, which is awesome. Okay, awesome. So this guy, this workup is actually ongoing right now. The team has ordered a bunch of this stuff, and Megan Altop on the fellows. It's a nice teaching off this morning. Mike, did you guys talk about IPF for ILD exacerbations this morning? Yeah, and what did you guys talk about in terms of like the ILD exacerbation? Great. So what would be the treatment if you were calling this an ILD exacerbation? So 1 mg per kg of steroids. Great. Awesome. Perfect. So 1 mg per kg of steroids, and how long do you use that for? Did you guys talk about it? Great. So the starting dose, 1 mg per kg. It can be, I think usually I've seen people get either the prednisone if they can take PO, or dexamethasone or hydrocortisone. But 1 mg per kg of steroids. And then how do you, like when do you consider this an IPF or an ILD exacerbation? What?
We talked about that, or as we think about the ILD, worsening ruled out everything else. So like we ruled out tension, 3 therapies, we ruled out it. But I ruled out those things.
Yeah, that's awesome. Love that. So Meryl said that anytime someone has ILD and worsening dyspnea, make sure you rule out the common stuff. So infection, volume overload, PE. And so, right, you're going to actually rule out most of these things with a CT, which is why this person got a CT-PE when they came in. So CT-PE, and then maybe an echo as well. So you can help rule that stuff out. And if you rule that stuff out, then you can call this an ILD exacerbation. And then you treat them with an anti-inflammatory steroid regimen to hopefully decrease the inflammation in their lungs. Dr. Chan, anything you would add about ILD exacerbations?
Yeah, I mean, it could be just progression of their disease, right? And sometimes they can have what they call acute interstitial pneumonitis on top of their chronic UIP. And I also noticed that maybe that his ILD may be a little bit worse on the right side. So you wonder, it's kind of controversial, but but people have talked a lot, especially Dr. Joyce Lee at university talks a lot about chronic aspiration in the setting of IPF, maybe worsening their disease. Yeah, you know, I think his disease is worse on the right side. His ILD is certainly. So you wonder about, you know, ask for symptoms of reflux, swallowing dysfunction, just empirically have head or bed elevation, because that's harmless to do.
Awesome. And you're saying, I'm assuming you're saying the right side just because that'd be the more common side to aspirate on?
Oh, yeah, yeah. Yeah, because the right mainstem bronchi is more obtuse from the trachea, and whereas the left mainstem bronchi is more acute at a more acute angle.
Great, that's awesome. Thank you for that teaching point. So maybe think if we see sort of right greater than left, consider chronic aspiration, elevate the head of the bed, and go from there. Awesome. Any additional questions from the room for Dr. Chan or thoughts on this case?
Also, I've heard some pulmonologists say that it's kind of debatable, like sometimes that does an ILD exacerbation this, or are we just missing the trigger, or is this just the progression of the disease and we're just growing steroid density? So I think with steroids, the mortality or death specific episode is like 50%, or something crazy like that. So I guess something interesting to ponder whether you're really treating this kind of exacerbation thing or whether it's just a last ditch effort to try and save the patient that's not doing well.
Yeah, super important point. Thank you, Eric. Yeah, so sort of similar to what Meryl was talking about with the cancer last week, right? The spectrum of like Felty syndrome and that crazy cancer that Corey talked about, the large granular lymphocytic leukemia. So like all these diseases, are we treating a spectrum of the illness or are they actually two separate entities? As a callback to Felty syndrome. I don't know, no one expected that out of nowhere. Cool. All right. Well, so just to reiterate what we talked about today, we talked about this person, two types of dyspnea. We talked about someone who had a maybe ILD exacerbation, but is getting worked up right now, and I'll fill you guys in next Zoom conference. And then we talked about a person who had a horrible symptomatic anemia, who is getting an EGD and a colonoscopy either today or in the very near future. Awesome. Well, thank you guys. Hopefully everyone learned something. And Dr. Chan, a huge thank you for helping out today.